I'm a hybrid vascular surgeon from Leypciге Center of St. Petersburg and an alien guy here. And I have nothing to disclose, and we will talk about a rare type of hybrid interventions or what you can do in a patient with long SFA CTO and extensive crural runoff problem. SFA lesions are frequent in PAD patients, reaching 70% in patients with CLI and tissue loss, and much high proportion of them being long CTO lesions accompanied by crural disaster. And conventional strategies would be either a total endovascular procedure or a long tibial bypass. So what speaks in favor of endo? Well, first, that's the global trend. It's becoming more and more popular both in the US and Europe. And basal trial have found no difference to open surgery, and we have large meta-analysis to show that endovascular strategy is non-inferior to open reconstruction. You can find publications with remarkably high patency in patients with long SFA CTO. What about the runoff? We know that the crural PTA is inferior to bypass as regards to patency. Still, it provides similar limb salvage rates. And there is randomized evidence to support this within basal trial. Another reason is that open reconstruction might be not so safe, because you can look at the early patency and complication rate in VascuNet reports, and the Critish registry gives us almost 20% early failures in tibial bypass group. Now let's see why surgery may be the superior strategy in this multi-level disease. First thing is that all recent guidelines lead us to do so, and performing tibial bypass has been a general practice. You can see that every second bypass in VascuNet report is a tibial bypass. This proportion is over a quarter in the US report, and most tibial bypass is done for long SFA lesions. So if you overcome the early problems, you can still have very durable result even with a very distal target. Yes, basal trial found no difference, but it mostly included short non-occlusive lesions. So do not expect your curve to be like this if you deal with long CTO, because we know that CTO is inferior and it gives worse result as regards to patency compared to stenosis. The same applies to tusk tube ossification. We're talking about poor runoff. You can see how strong is the negative effect on patency. All these considerations made us implement the concept of distal hybrid. The first part of the intervention is vein bypass to the popliteal segment, which gives us higher patency compared to endovascular. Shorter bypass compared to tibial bypass gives us less likelihood of restenosis. And even in the event that we fail to preserve the foot, we do not have to ligate the bypass when we do the below the knee amputation. The second part is crural PTA that provides direct vascularization, and if the bypass is still functioning, reocclusion of tibial vessel will not lead to CLI recurrence. The cornerstone question is it safe to perform a vein bypass to an isolated popliteal segment? Yes, we can do that. And largely we know that because we see how durable a vein bypass can be in the settings of poor outflow. Finally, this is supported by latest guidelines. So this is our patient group, all patients with CLI and tissue loss. All had long SFA CTO accompanied in most cases by 3-vessel disease, outflow disease. Hybrid procedure was staged in nearly half of all cases, with crural PTA being done several days later through crossover approach. In case of simultaneous hybrids, we used side branch access to improve outflow. On the popliteal and crural level, we did OBA with Armada balloon, achieving over 90% rate of direct vascularization. So we did not use clopidogrel on the open stage, even for simultaneous hybrids. These are early complications. Both failures occurred in simultaneous hybrid group. Patency analysis shows that even when the crural arteries are reoccluded, the bypass still functions and provides significant amputation-free survival. This is the first case of a patient with long SFA CTA and 3-vessel crural disease. We did a simultaneous hybrid. You can see the introducer advanced to the side branch. we managed to recanalize and open all 3 vessels, providing direct foot revascularization. This is the result. In 1.5 years, the bypass is functioning, although all tibial vessels are reoccluded and foot healed, and there is no sign of critical ischemia. Another case with longest FACTO and cruel disaster. We did a stage hybrid several days after making bypass. We came through crossover approach and we managed to do PTA of the 2 tibial vessels. So to conclude, distal hybrids are an option in these patients. Despite outflow reocclusion, the functioning bypass will still prevent CLI reoccurrence. Of course, we need larger studies comparing this strategy to tibial bypass, and we need a flow meter. Thank you, I'm done.
So in the United States, what's interesting is some of our vascular surgeons are judged by the patency of their FemPop bypasses. Saying that, do you ever open up the tibial vessels first and then come back and bypass? For example, downstick the popliteal, open up the tibials, and then you come in and do your bypass?
No, we're not doing this because intentionally. Because there is a large proportion of patients with an isolated popliteal segment in whom bypass will by itself be enough. Because the patient may have a very superficial minor tissue loss, and by observing the effect during the first days after the bypass, you may decide that the patient doesn't need crural angioplasty at all. So this is a very high proportion of patients. If you look at the studies concerning the bypasses to isolated popliteal segment, that there is like 6 to 10% rate of amputation with functioning bypass. So majority of patients are contracting with the bypass, at least if we trust the literature.
You use non-invasive measures to decide that, toe pressures, or I mean, how do you decide if it's enough?
Well, clinical criteria, pain, is it gone or not, and the second is toe pressure.
Any questions now? Wonderful presentation. Thank you very much. So our next presentation will be by Dr. Raskin.